When a solid mass abruptly obstructs a closed biological channel, the physics of the system change instantly. Fluid continues to secrete, but with nowhere to go, intraluminal pressure spikes, stretching the surrounding tissue and setting off a violent, localized inflammatory response. In clinical practice, acute calculus cholecystitis represents the entry point to a rapid, life-threatening continuum of physiological escalation. Successfully managing gallbladder emergencies requires executing rapid clinical pivots based entirely on a patient's shifting hemodynamic stability metrics. This timeline maps that precise clinical and anatomical progression. We will track the pathology from a simple calculus to a localized empyema into ischemic gangrene and finally structural perforation. Recognizing exactly where a patient sits on this continuum is the only reliable method to anticipate structural failure before it happens, dictating interventions that prevent mortality. We begin at the baseline with a standard presentation. Looking at this patient chart, we see a 45-year-old female presenting with 24 hours of right upper quadrant pain, fever, nausea, vomiting, a positive Murphy's sign on physical exam, and an elevated white blood cell count. The underlying pathophysiology here is entirely mechanical. A gallstone impacts the cystic duct. The mucosal lining continues to secrete mucus, but the outflow is blocked. The intraluminal pressure rises, compressing the venous drainage and causing the mucosal wall to engorge and thicken. Immediate resuscitation targets stabilizing the patient and quantifying the inflammatory response. This means strict nil per os, establishing 2 IV cannulas for crystalloid fluids like normal saline or Rinner's lactate, and drawing labs. A complete blood count and CRP measure the systemic inflammation, while liver and renal function tests, alongside serum amylase and lipase, rule out concurrent biliary tree obstruction or pancreatitis. Ultrasound is the mandatory first-line imaging modality. A positive diagnosis requires 4 specific sonographic criteria: the visual confirmation of gallstones, a thickened gallbladder wall exceeding 3 millimeters, the presence of pericholecystic fluid, and a sonographic Murphy sign elicited directly by the ultrasound probe. Medical treatment in this baseline phase focuses on strict source control. Analgesia is achieved with NSAIDs or opioids, followed immediately by targeted antibiotics. The standard regimens are ceftriaxone combined with metronidazole or piperacillin tazobactam. Definitive treatment requires physical removal of the obstructed organ. An early laparoscopic cholecystectomy should be performed ideally within 72 hours of symptom onset, though protocols allow it up to 7 days out. Operating early is structurally and systemically advantageous. It significantly lowers overall morbidity, shortens the patient's hospital stay, and eliminates the risk of recurrent, increasingly severe attacks. However, if systemic comorbidities render the patient unfit for general anesthesia, the algorithm pivots. A percutaneous cholecystostomy tube is placed to manually drain the pressure, acting as a temporizing bridge until an interval cholecystectomy can be performed safely. By combining aggressive fluid resuscitation, targeted antibiotics, and strictly timed surgical source control, clinicians halt the inflammatory cascade, preventing the trapped fluid from festering into a systemic infection. If that baseline obstruction is left unchecked, the clinical picture rapidly deteriorates. Consider a diabetic patient who suddenly presents with high fever, severe rigors, a highly toxic clinical appearance, and a white blood cell count spiking to 22,000. The sterile fluid trapped inside the gallbladder has now become heavily infected. This localized purulent accumulation within the pressurized lumen is defined as an empyema. This chart tracks the mandatory shift in clinical management. Standard care is immediately abandoned in favor of a dedicated sepsis protocol. This requires supplemental oxygen, continuous lactate monitoring to gauge tissue perfusion, and highly aggressive intravenous fluid resuscitation. Pharmacological coverage also escalates. Broad-spectrum agents are required to target the severe, overwhelming bacterial load. While piperacillin tazobactam is still utilized, severe sepsis demands upgrading to carbapenems like meropenem. The surgical decision now hinges entirely on the patient's immediate hemodynamics. If the patient remains stable under the sepsis protocol, an emergency laparoscopic or open cholecystectomy is performed. If the patient is hemodynamically unstable, surgery is too hazardous and a percutaneous cholecystostomy is placed for rapid, less invasive decompression. The transition to an empyema eliminates any option for elective scheduling. The priority is immediate, life-saving source control to stop the systemic spread of infection. The escalation continues when microvascular failure sets in. Clinically, this presents as the sudden, precipitous deterioration of an elderly patient, often diabetic, who was previously diagnosed with simple cholecystitis. As intraluminal pressure exceeds capillary perfusion pressure, the venous drainage collapses entirely. With the blood trapped, arterial inflow is choked off. The resulting ischemia causes the gallbladder wall tissue to infarct and necrose, turning necrotic and black. This microvascular vulnerability makes diabetes mellitus the most common and dangerous risk factor for progressing to gangrenous cholecystitis. Because ultrasound struggles to differentiate viable tissue from necrosis, the diagnostic protocol shifts. A CT of the abdomen becomes mandatory to accurately assess the extent of the dead tissue and evaluate for impending structural failure. Emergency cholecystectomy is required, but the operative field is severely compromised. The necrotic tissue is friable, bleeding is difficult to control, and anatomical landmarks are obscured. This results in an exceptionally difficult surgery with a highly elevated rate of conversion to an open laparotomy. Gangrenous cholecystitis represents a rigid point of no return. The tissue death transforms the local anatomy into a mechanically hostile environment, increasing the physical hazard of any surgical intervention. The final stage of the continuum is catastrophic. The patient's localized pain suddenly shifts to generalized abdominal agony, quickly followed by the clinical markers of peritonitis and profound septic shock. The ischemic necrotic wall of the gallbladder has completely ruptured. The pressurized, highly contaminated bile spills directly into the sterile peritoneal cavity. Resuscitation at this stage requires immediate, maximum systemic support. High-flow oxygen is administered. 2 large-bore IV lines push aggressive fluid resuscitation, and blood is cross-matched in preparation for severe operative bleeding. This flowchart outlines the mandatory surgical sequence to manage the perforation. First, an exploratory laparoscopy or laparotomy establishes access. Second, the surgical team drains the bulk of the contaminated bile. Third, a massive peritoneal wash-ob is performed to clear the abdominal cavity of infectious debris. Only after the cavity is flushed is Step 4 executed, the actual cholecystectomy. Finally, Step 5 requires placing surgical drains before closing. Postoperatively, the patient is immediately transferred to the ICU for continued aggressive sepsis management. Perforation shifts the surgical requirement to extensive, whole-cavity decontamination to sustain the patient's life. The biliary escalation continuum is a predictable progression. A simple calculus leads to pressurized empyema, collapsing blood flow to cause gangrene, ending and perforation. Preventing catastrophe depends on recognizing clinical transitions. Toxic signs point to empyema. Sudden deterioration signals ischemia. Shock confirms perforation. As the pathology deepens, so must the pharmacological response, escalating from standard targeted antibiotics to maximum broad-spectrum coverage to combat mounting sepsis. This 2x2 matrix represents the ultimate triage rule. Intervention is dictated entirely by hemodynamics. Surgical removal is the definitive cure for a stable patient, but percutaneous drainage is mandatory damage control for the unstable patient, relieving pressure until vitals permit surgery. Mastering these emergencies require objective risk stratification and strictly timed algorithmic interventions that stop the continuum before it reaches its lethal end.